who comes for glycemic control. He was advised to come to us only because of an ophthalmological complication, and he was advised to undergo a intervention in his eye. And reading his fundus report, there was bilateral severe proliferative diabetic retinopathy and severe clinically significant macular edema in the right eye. A1C is 9.6, fasting is 256, PP is 302, and he's already on metformin, glipizide, metformin, glimepiride, pioglitazone, gliptin, calcium channel blockers, multivitamins. What alteration can be done to his medications and rationalize it? Put down the answers there. Macular edema, pioglitazone to be stopped. Very good. What else? See, can you use gliptin in this patient? Any contraindication for gliptins? Ayushnu came with an answer. 17 years of diabetes, sulfonylurea stopped already, burnt out pancreas. Okay. Already weight gain. Not getting you. Gliptins already weight gain. I don't get you. What's meant by that? Okay. I don't want to beat around the bush. I'll go with the answer here. See, can we use gliptin in this patient? Yes, using gliptin will not be of much benefit, but still we can use this patient's weight neutral drug. Yes, we can continue the patients with gliptin. The metformin, of course, you can use. You have to just check whether the patient is having renal ailments, because if they have the diabetic retinopathy, that to this extent, they will definitely have diabetic nephropathy also. Okay, that is also a microvascular complication. So always check creatinine level, check their EGFR, and then decide on keeping the dose of metformin. Pioglitazone, as Swati rightly mentioned, pioglitazone is notorious to cause more fluid retention and it may aggravate the macular edema. So it is absolutely contraindicated in this patient. We'll have to stop pioglitazone. When we think about insulin also, we should be very careful, because when you aggressively manage the diabetes in this patient, again macular edema worsens. Not only macular edema, when you give the patient aggressive insulin therapy, there is a very high risk of the proliferative diabetic retinopathy also getting worsened, because insulin also acts through the IGF-1 receptors, and by causing increased proliferation, the proliferative diabetic retinopathy may get worsened. Okay, so pioglitazone has to be stopped. When you use in insulin, be cautious about the doses and the aggressive management in insulin therapy. Sulfonylureas, yes, you can keep the sulfonylureas, and as Sandeep said, definitely the patient would have a burnt out pancreas, is what he mentioned. But look at his fasting blood sugar and PP. From fasting to the PP, we have just 50 milligram per DL difference. That means postprandial exertion is not a big problem here. We have a problem with curtailing the fasting blood glucose here. That means the patient has high levels of insulin resistance. So some insulin sensitizers would be the best option here, which already is given here. We have already given metformin. These patients may still benefit from SGLT2 therapies. Okay, SGLT2 therapies can be given. It's not contraindicated in patients with diabetic retinopathy. It will cause a certain level of glucose drop. Fasting postprandial, it doesn't bother. It causes a certain level of GLP drop. Insulin sensitizers, yes, gliptin, metformin you can give. Can you give thiazolidine? No. What else is there? GLP-1 analogs are there. But mark the point that semaglutide GLP-1, which is used in diabetes, is absolutely contraindicated in proliferative diabetic retinopathy. It has been known to aggravate the proliferative diabetic retinopathy. So usually when we use GLP-1 analog, this red flag sign should be brought in our mind. Don't use semaglutide in proliferative diabetic retinopathy diabetics. And yes, this patient may benefit from basal insulin. If you give a nice dose of basal insulin, his fasting blood glucose will automatically drop. And from the fasting, we have just 50 milligram difference, which can be well managed with your sulfonylurea. And CCB is given in this patient. Can we give the patient ARBs instead of CCBs, because ARBs are notorious to prevent the progression of diabetic retinopathy. So look into the kidney. If there is no absolute contraindication, ARBs can be used. And of course, any diabetic retinopathy patient, even if they have dyslipidemia or not, they are ideal candidate for statin-based therapy. Anti-dyslipidemic therapy should be ideally kept in these patients. Okay, so finally, this would be the answer. Keep the patient on gliptin metformin. Metformin, consider the CKD EGFR status of this patient and adjust the dose accordingly. If it is inadequate dose, increase the dose also, no issues, because the fasting is very higher in this patient. Stop pioglitazone and put the patient on a base of insulin. Continue sulfonylurea, and you can reduce the dose of CCB and add a ARB and put a statin. Okay, so once the glucose control should be very slow and steady. Overnight, you shouldn't take absolute control. Like today it is 256, tomorrow it shouldn't be 80. Slow, steadily you have to take control. So aggressively you don't manage. 1 or 2 weeks you take your own time, slow reduction you do, and then send the patient for the eye intervention. Okay. So today in this weekend we will discuss about the complications in diabetes. In diabetes we have vascular complication, non-vascular complication. Vascular, as you all know, micro and macrovascular complication. So micro usually happens around the second decade of the hyperglycemia. SGLT2 use in diabetic foot ulcer. This patient doesn't have diabetic. Oh, you are asking in general, right? Yeah, that is a controversial subject. Generally, what they do is in SGLT2 inhibitor also the risk of amputation is bit increased. Okay, that they have noted in certain trials. What they proposed is the SGLT2 is notorious to cause a level of dehydration, right? Already the diabetic patients would be uncontrolled if they have a diabetic foot ulcer. So already they will have a pro-inflammatory state, which is again translating as a pro-thrombotic state. So they already have a high risk for thrombosis. So if you have a dehydrating condition, this prothrombotic state gets aggravated. Okay, and usually in some patients who already have a subtle subacute thrombosis, this thrombosis aggravates and this blocks the vessel, and that is the reason behind amputation. So SGLT2 inhibitors in active diabetic foot ulcers, in any active infection, we stop SGLT2 inhibitors temporarily because of the risk of diabetic ketoacidosis. Okay, for that reason, we stop. Once the patient is out of that infection, once the infection gets controlled, we again restart. But those with the previous history of thrombosis, we generally have to be very careful, and we generally don't give SGLT2 inhibitors. Okay, so don't put it under a broader spectrum of diabetic foot ulcer. Diabetic foot ulcer with the thrombosis, be very careful. Don't start SGLT2 inhibitors. Okay, and in any active florid diabetic foot ulcer also, in the active phase, don't put a patient on SGLT2 inhibitor. So this would be the answer. Okay. So microvascular complication usually happens around second decade of hyperglycemia. Macrovascular usually translates as coronary heart disease and dyslipidemia along with stroke. That usually develops even before hyperglycemia. Look at the irony here. So, when you have high glucose levels in your blood, after 20 years of hyperglycemia, you may have microvascular complication. But even in your pre-diabetic stage, you are at higher risk for macrovascular complication. That is because of insulin resistance directly. Okay, so always remember, even if you're a pre-diabetic, get back to a non-diabetic state. Don't stay in the pre-diabetic state, because the moment you go into the pre-diabetic state, you are at high macrovascular complication risk. Okay, what are the non-vascular complications? Infections, skin changes, hearing loss, and increased risk of dementia and cognitive dysfunction. These are all the macro and the non-vascular complications of diabetes. So moving on to diabetic retinopathy, to make you remember easier, remember about AAON. AAON is ophthalmic condition, anterior ischemic optic neuropathy. So A for AG accumulation, I for inflammation, O for oxidative stress, and N for neovascularization, and all happening because of one important factor, and that is not insulin resistance, that is hyperglycemia. Okay, that is the reason why in severe insulin dependent diabetes, because of the insulin deficiency, because of the hyperglycemia, you are at high risk of retinopathy. Whereas in insulin resistant obese diabetes, because of the insulin resistance, you are high risk of CKD and coronary artery disease. Okay, so if you see, all these things would be secondary to hyperglycemia only. Hyperglycemia per se will increase your pro-inflammatory markers. Hyperglycemia will activate the alternative glucose metabolism cycle, polyol cycle, PKC pathway, hexosamine pathway. And because of the reactive oxygen stress will develop. Okay, and hyperglycemia again because of the activation of the alternative pathways and because of the formation of all these abnormal glucose metabolites in between increases the advanced glycation end products. Okay, and it activates the hypoxic inducing factor because of the insulin deficiency. Nitric oxide won't be there, hypoxia will be there, hypoxic inducing factor will get activated, and this activates vascular endothelial growth factor, and this is the reason behind neovascularization. So remember AAON, A for IgG accumulation, I for inflammation, O for oxidative stress, and N for neovascularization. So you have two types of retinopathy in diabetes. One is proliferative, the other one is non-proliferative diabetic retinopathy. Non-proliferative usually starts around 10 to 15 years. Sorry, 15 to 20 years. It usually starts around. Um, usually starts around. Okay, so you have non-proliferative diabetic, that means neovascularization has not happened here, there's no proliferation at all, only those vessels that had been there earlier will undergo a damage, and because of a damage the vessels will look different. So what sort of difference you will see in the vessels? You could see the vessels basement membrane getting damaged, the podocytes or the supporting cells will not be there, they will get damaged, and the basement membrane will also get damaged. Because of that, what happens? This is damaged. So you will get micro aneurysm. Okay, because of the damage, small damage, small dot and blot hemorrhages you could see. Okay, and it causes a certain level of vascular insufficiency to your small nerves within your retina, not to the blood vessel. The nerves would be supplied by vasa nervosa, no? So that would be damaged, and because of that, axonal cytoplasm will not be moved and it will start to clog here, and this will is called as cotton wool spots or soft exudates. This is what we tell them as. Hard exudates are due to the mobilization of all these cells from the blood vessels into the exterior. That is hard exudates. That is something which is different. So you have microaneurysm, dot hemorrhages, lot hemorrhages, cotton wool spot, and hard exudates. And that is all because of loss of retinal supporting cells. That increases the vascular permeability. There will be alterations in the blood flow, abnormal retinal microvasculature, everything amounting to retinal ischemia. So you could see this is a hard exudate. This is axial exudate. Hard exudate is an axial exudate. It is not axoplasmic flow interruption. It is just the exudation. This is blot hemorrhage. Can you see the blot hemorrhage? You could see a blot hemorrhage. Blot hemorrhages would be like small dots would be there. This is microaneurysm. A small this thing you are seeing here. No, this is microaneurysm, and this is a normal blood vessel that you could not see. So if you see something like this, it's a non-proliferative diabetic retinopathy. Again, we have all these differences. Those interested in ophthalmology can go and look into it. Sometimes MCQs can be asked out of it, but always remember mild, moderate, severe, and very severe. Four categories are there. Moderate and severe, remember 3-to-1 rule and 4-to-1 rule. That literally means one microaneurysm in at least three quadrants. One microaneurysm or dot blot hemorrhage in three quadrants should be there. 4-to-1 rule is dot blot hemorrhage should be in all the four quadrants. With at least two quadrants, you should have venous bleeding, and one quadrant, one quadrant IRMA should be there. Venous bleeding or IRMA should be there. Very severe is two or more characteristics of this NPDR in absence of neovascularization. Okay. So this is about the classification of the NPDR. So non-proliferation is different from proliferation. In proliferation, almost because of severe hypoxia, neovascularization starts happening. Okay, so VEGF starts increasing and you get neovascular, small vessels will develop. But these vessels, no, they start developing from the retina here into the vitreous chamber. They start developing. Usually, when a vessel develops, no, they should have a support, but these will be growing in a perpendicular manner into the vitreous region like this. They will not have support. So because of that, they start to break and they start to hemorrhage. So you get new vessels appearing near the optic nerve or macula, and they rupture easily. That causes vitreous hemorrhage. Once hemorrhage, fibrosis will happen, right? So once fibrosis happens in this part, it will pull the retina from behind. It is called as retinal detachment. So these things tend to happen, and macular edema also happens because of the hypoxia and the nerve damage. Macular edema can happen, and this can happen both in proliferative diabetic retinopathy and non-proliferative diabetic retinopathy. Clinically significant macular edema, only in proliferation it will not happen. It can happen anytime, anywhere. Okay, and duration of diabetes and the degree of the glycemic control are the best predictor of the retinopathy. But apart from that, hypertension, nephropathy, and dyslipidemia are also risk factors. So this is neovascularization. And when you see this is proliferative diabetic retinopathy, you have two types of proliferative diabetic retinopathy. You have neovascularization of the disc and neovascularization elsewhere. So this is the disc. Okay. So when you get a neovascularization within one disc diameter of the optic disc, that is called neovascularization of the disc. When it goes beyond it, that is neovascularization elsewhere. Okay. So the again it is of two types: early PDR and high risk PDR. So early PDR, at least if you are doing some intervention, eye vision can be changed, but in advanced PDR, nothing can be done. They are very poor prognosis. Okay, so to detect macular edema, usually the best test option would be fluorescent angiography or OCT. It is called as optic coherence tomography. This is fluorescent angiogram. So this is the fluorescent angiogram that you usually see. Can you see? And the fluorescent dye is given. So usually in areas of edema, it will start to accumulate. So this is the cystoid macular edema. This is the region of macula. This is optic disc. So you could see the cystoid macular edema. This is optic coherence tomography, which will delineate the different layers in the macular part. And you could see the subretinal fluid and intraretinal fluid in the macular region. So it will tell the degree of the macular edema, and accordingly we can decide on the treatment. Okay. So usually in diabetic retinopathy, prevention always comes first. And I told you earlier, 20 years it will take to develop diabetic retinopathy, but in SID varieties, usually it occurs earlier. In 10 years, only you will start developing everything. So intensive glycemic control is very important. BP control and dyslipidemia control is also very important. So what would be the treatment option here? Generally, I'm telling you, treatment option is with respect to ophthalmology, you have to go ahead with prophylactic laser photocoagulation. So what do? They give laser pulses and they burn your retina. By burning your retina, you literally burn the particular area, no? So no hypoxia would be there. The hypoxic signal is directly translated to anoxia. Okay, so VEGFR will not develop and proliferation will not happen. So wherever this point is, this proliferation is happening, they will give thermal burns here and there. So that region will completely be anoxic and VEGFR will not happen. And what they have found out in recent studies is in pancreatic or islet transplantation, they have seen the diabetic retinopathy improving. Okay, so always plan pregnancy. When you are planning pregnancy, you will have to screen diabetic retinopathy and then go for pregnancy, because pregnancy worsens diabetic retinopathy because all the growth factor is coming from the placenta, and because of the vascular expansion happening within the mother, it usually worsen. Advanced retinopathy, usually if you have improved glycemic control also, it will be of less benefit only. So apart from the laser photocoagulation, what are the other options? VEGF inhibitors are also wonderful option. They are also being tried. So lower always the triglycerides with the fenofibrate. Fenofibrate is studied to have good benefits with respect to retinopathy. It reduces the progression of retinopathy. For macular edema and all, you will have to go for laser photocoagulation anti-VEGF therapy, which is given intravitreously, directly into the eye. Okay, and if there is a heavy bleed, fibrosis, retinal detachment, and all, they may be even ideal candidate for vitrectomy. They will remove the vitreous humor and they will insert a oil-like substance into it, which is a docile oil, which will not have any reaction with the retina. So that is about diabetic retinopathy. Okay.